for the June COVID-19 dissemination meeting. My name is Kuta Bandamhango with the National Health Research Authority. We appreciate you taking the time to join us. This is 10:06. We will be starting now. The facilitator will be joining us shortly. She had a few challenges with connectivity, so she will be joining us shortly. Before we get started, I am going to invite the director, Professor Godfrey Biemba, to just give us some opening remarks, and then we will get straight to, we're going to have a few instructions to give to the presenters, and then we go straight to the presentation. Director.
Thank you so much, Kuta, and good morning, everyone. I want to appreciate for your commitment to these dissemination meetings. I just want to emphasize that they are not routine. They are meant to bring out the evidence as it comes out from the field and ensure that we actually utilize that evidence as it comes out from the field. And that's the emphasis. The emphasis is that we just don't want to produce evidence that is not useful. We want to ensure that the evidence is part of the COVID-19 response. And so I want to appreciate the presenters, specifically Professor Faston Gomash. He's been really an advocate of evidence generation and evidence knowledge translation. And he recently facilitated a workshop where we all got a lot of information on COVID-19. And we appreciate what you're doing, Prof. Goma. I want to appreciate also Dr. Lombe for coming through with a very, very important topic that I hope that we'll be able to get something that can be plowed back into our response to COVID-19 pandemic. I don't intend to spend much time in the introduction and welcoming remarks, except to welcome all of you. What I want just to appeal to you is please advertise these meetings. Send the link to all your colleagues and your networks. We want as many people as possible to know what is happening as far as evidence on COVID-19 is concerned that is generated in Zambia. That's the idea of this monthly COVID-19 dissemination meetings. So send the link to everyone in your network so that they are able to attend. Our first meeting, we were oversubscribed and we had increased to 1,000. So this network, this Zoom meeting can accommodate up to 1,000 people. That means that you can invite as many people as possible so that they are able to be part of this dissemination. So back to you, Kuta. Thank you so much. Welcome, everyone.
Thank you, Director. I have actually seen the facilitator is in. So before, okay, I thought I saw her. All right. So for the presenters, for everyone, a few ground rules, we request you to utilize the chat. Please introduce yourself in the chat, send in your name, your affiliation there. And as the presentations are going on, if you have any comments, any submission, please feel free to type it in the chat box. And for the presenters, when you're done with your presentation, we request you to pay attention to the chat and see if there are any comments or questions for you to address so that when we come to the Q&A session, you are able to take them on. And then for the presenters as well, you have 15 minutes to make your presentation. We will give you a small allowance should there be need for you to extend or to continue with your presentation. So you will see my colleagues Just pay attention to my colleagues, Ben Mambo and Mabuchi. One of them is going to be holding up a poster like this one when you have 2 minutes. So just pay attention to the video. We don't want to disturb you. You are going to have a poster that will be raised to show that you have 2 minutes. And then when it is time up, you're going to have another poster that is going to be put up with an alarm that will sound to show that it is time up. We want to give you as much time as possible, but we also recognize that this meeting is supposed to take about an hour, at most 1 hour, 15 minutes. So we hope that you do pay attention to those. We're going to have the Q&A come after both presentations so that we save a bit on some time. All the discussions, some can go in the chats, and for those that want to ask or those that want to contribute, please wait for the Q&A session that will come after the 2 presentations. So without wasting a lot of your time, I would like to invite the first presenter, Professor Goma. You should be able to share your screen. We request that when you are making your presentation to make this a bit interactive, if you're able to, please turn on your video. Yes, thank you. Thank you. Please turn on your video. And same with you, Dr. Lombe. If you're able to, when presenting, please turn on your video. Thank you so much, and over to you, Prof.
Thank you very much, Madam. And I should say, it's our great pleasure to participate in this good dissemination meeting. And I think, as Prof. Biemba has already said, we are great advocates of knowledge translation, and especially, trying to make use of local evidence. Eden University has been getting very, very actively involved in research, and I think our research portfolio grows by the day. And what I'm going to share with you this morning is some findings from a research project that was sponsored by National Science and Technology Council at the beginning of the pandemic last year. And I thought, that we found certain things that we need to work on as we move forward to try and see how well we can mitigate the effects of the pandemic. So in this research project, we looked at environmental risk factors that may be contributing to the transmission of COVID-19 in Zambia. We think that whatever we do, we must have concrete evidence for doing it, and we must see that people are adhering to what we advise coming from scientific evidence. So we generated this research project on the basis that, well, there was a lot of evidence that there were environmental factors which played a significant role in influencing COVID-19 transmission the world over. And because of that, we were given the 5 golden rules that needed to be followed. But ours really was to try and find out how this transmission was taking place. We looked at a few studies which had been published by that time, and well, they did say that the virus was actually being transmitted from person to person, and it would actually be transmitted from particular surfaces. And there was evidence that the virus could live on a plastic or stainless steel surface for 2 to 3 days. So if you touch that surface, you may get infected. Cardboards, well, just a day. After a day, the virus would then die off, but it would stay on a card box for at least 24 hours. And it would also really stay on a copper surface, though we know that copper is very, very toxic to the virus, but it would actually stay on a copper surface for up to 4 hours. And another study from China showed that, SARS-CoV-2 could be found on floors where people have been coughing. They could be found on the computer mice, where people have been handling the mice with infected hands. You could find it, on cans, and you could actually find it on sickbed rails, okay? Meaning that people who had COVID contamination on their hands could actually leave it on many other surfaces. And so we crafted our objective to try and find out how that was happening in Zambia, because I mean, our environment is slightly different from that of China. We have a drier environment, and our temperatures are a bit on the warmer side. So how well is the virus surviving on these surfaces, and how contaminated is the environment where HIV-infected persons stay? So we were actually going to go into the homes of the people who are infected with COVID-19 to try and see how contaminated their surrounding was. And then we looked at the contributory factors to cross-infections. In the house where this person is found, how many other people are there, how well are they using their masks, and how are they disposing their face masks. But really, I may not talk so much about the occupancy density or the method of disposal, because my insistence will be on environmental surfaces and environmental transmission of SARS-CoV-2. So for those who are deep into research, we should say that this was a cross-sectional study which was done in Lusaka, and we actually contacted the Zambia National Public Health Institute to give us the names of the people who they were doing contact tracing on. You remember in wave 1, every time someone tests positive, the team would then follow that person up to their homes, and then they would do contact tracing beyond that particular person. So we worked with ZNPHI to show us homes where we had people who had HIV, who had SARS-CoV-2 infections. And then we went into those homes and collected our samples from there. In the different homes, we were looking at door handles, okay? These infected patients do open doors in the house. They play around with the taps, they press light switches, and then as they cough, is there some of the droplets that are falling on the floor? What about tables and probably chairs? And what about these handrails? And then we went as far as looking at also their mobile phones. Was there any virus on the mobile phone? You know how close the mobile phone gets to the mouth and to the nose. And as I said, we did look at the face masks they were using and how they were disposing them. We would actually go into those homes and would try to get the swabs and send them to the virology lab at University of Zambia School of Medicine. We'll try and get the swab there within 2 hours of collecting the swab to make sure that the sample was still viable, that the virus does not die in the process. We wanted to make sure that the virus got there still alive, if it was alive. The laboratory at School of Veterinary Medicine is a B3 lab, one of the best labs we have in Zambia. And I think we must say that, you know, we are proud of that investment, and we are proud of our colleagues there. They are doing a very, very good job. This lab can actually do genetic analysis, meaning that if we find SARS-CoV-2 in one person and find it in the other person within the same home, the question we wanted to ask is, are the two the same viruses, or did they get the virus from different places? So we were actually able to do that genetic analysis just to try and see the relationship among the viruses. That is why now we are able to actually get down to knowing the mutations that are taking place, just to try and see which ones we are dealing with in Zambia. That's now the processes at the lab. Really very, very detailed and very, very scientific process of trying to identify the virus. So we would subject the swabs to 2 different tests. The first one was to try and see whether there was any virus on the swab. And if the test was positive, then we would take it into the next process, which was to say, is the virus alive? Okay. And that's just a photo of the different surfaces that we swabbed. So you can see we are swabbing the mobile phone surface, okay? People usually don't touch that surface, but it gets very, very close to the nose and to the mouth. So we are trying to see, is there any virus there? Then what about the toilet handles where the patients press? What about the light switches? And we even swabbed their face masks, okay? Then the door handles, and we were all, as I said already, trying to find out if there's any virus there, and if the virus was there, is this virus alive at all? And that was our result, okay? So we swabbed 210 surfaces. From those surfaces, 44 were positive, meaning that there was a virus present on 44 surfaces. But when we tried to see how much of this virus was still alive, only 1 out of the 44 surfaces had actually live virus. And looking at the different swabbed surfaces where we got our samples from, we could see that the highest places which had virus were mobile phones, okay? Again, just to show that the closer an object is to the nose and mouth, the more vulnerable it is, the more likely it is to get the viral infection. And on door handles, okay? Which means that, you know, hands are real carriers. But switches and fridge handles, there was no virus there at all. And then when we looked at the beddings, at least 1 bedding had virus on it. And then the remote control also, that's because of again, handling. We looked at 40 households, and we could see that in all the households we looked at, there was a very, very high density of people staying in each home. And I think this is the fear that we have now, that, you know, the more the people, the more the infection would spread. And when we looked at the face masks that these patients and their relatives were using, 62% were using recyclable. These are masks, cloth masks, which you can wash and press and dry. And just 48%, 48% of the people were using non-recyclable, meaning that they were using disposable face masks. We should, I almost said we should apologize for a small sample size, but we shouldn't apologize for that, because the funding for this study was very small, and so we could only afford that small sample size. But even from there, we are able to share our findings with you. And these, I think, were the major findings from this study. One, that SARS-CoV-2 was actually present on contact surfaces, meaning on surfaces where hands were getting into, were touching, so to say. So those surfaces where hands were touching were very, very prone to getting SARS-CoV-2. But it very much looks like open environmental surfaces did not really have any virus. Otherwise, we would have seen it landing on the fridges or landing on the wall or on the walls of the house or on the light switches, but there was no virus there. So we can see from here that really it's the proximity to the nasal aerosols or to the droplets that was a major risk factor to contamination. This has implications to prevention, and I really think that we need to look at that closely. Hands and handling of objects were a major source of contamination as well. It looks like the environment per se has a negligible role to play, meaning that this virus doesn't seem to be airborne, okay? It's actually and I think that, what then are our recommendations? And this, I think, is what now brings us to knowledge translation. First of all, we should say that we need to insist on the use of face masks, appropriate use of face masks. Infected persons especially must use N95 masks. It's very, very important here to say that, yes, this transmission is from aerosols, and we need to use masks that are effective in filtering aerosols. And these aerosols, we know, can be as small as 95 nanometers. And in certain instances, they should be as small as 2.5 nanomoles, okay? Meaning that the face masks that we are using, especially in hospital, must be those which can filter the virus and filter it well. Cloth masks do not work. Surgical masks are not that good. Meaning that if someone is infected with this virus, can we insist on N95s being used? Meaning that patients admitted to hospital must have their N95 masks. Health workers, okay, working within that environment must also use the N95s. If we can't manage the N95s, probably we need to go for double masking of the surgical masks. But it's very, very important that I think we take that message home. For the health workers, the ones who are getting very close to patients, and I think the other day I was complaining about us who deal with the heart and those who deal with lungs, we have to listen to the heart. And the stethoscope is not more than 1 meter long. You have to be close to the patient, okay? So for those health workers, we need to use proper respirators, masks which can filter up to 2.5 nanomoles. Okay, these masks which can deal with these small drops, which we call PM 2.5. These are mostly called respirators. I really think we must bring them in, and we must bring them in urgently. All the health workers working in the COVID wards must use respirators, not surgical masks, and probably not even N95s. N95s can be used by the cleaners who are still away from patients or who are just cleaning up the surfaces. But those who are getting close to the patients, I think we need to protect them better. Let's go for respirators for the health workers, for the doctors, the nurses, and the physios, and all those who get so close to the patients. We need to get respirators in. The others, N95s, or double masking of surgical masks. But let us leave surgical masks really for the people who are riding minibuses or people who are getting into places where they may meet other people. Then there's the issue of social distancing. I really think that, we must try and relate our environment to the size of the droplets we're expecting in this jurisdiction. Yes, while as, the aerosols would drop within 2 meters, if they are heavy and humid. In our surrounding, in our environment, these aerosols are bound to be smaller in size, and so they would fly further. Meaning that the social distancing at this time should actually be put at 2 meters. The 1 meter or 1.5 we've been talking about, I really think that we must discard that. The SARS-CoV-2 is spreading very fast in Zambia right now, and it's because our weather is not that humid, okay? And so the droplets are bound to be smaller and lighter, and they will go further. And so can we put this social distancing at 2 meters, please? Okay, meaning that, this greeting of, elbow to elbow must stop. I think let's greet fist to fist. Okay, because your fist is 1 meter to your neighbor, and his fist will also be 1 meter to you, 2 meters. That would be the best greeting that we can have. So shoulder to shoulder or elbow to elbow must stop. Let's move now to fist to fist. Hand hygiene should be continued. We need to sanitize. It's good. I think we are seeing very few people shaking hands now, which is extremely good. but can we make sure that we sanitize and we wash our hands frequently and wash them with soap? In those places where we have colleagues who are infected, I think we need to promptly disinfect surfaces where we think that there may have been droplets. So cleaning should be very, very effective. And especially in the hospital, I think we need to increase the density of cleaners in the hospitals and give them some disinfectant. We must make sure that all the COVID wards are spotlessly clean and the surfaces must be dry. Okay. And then these findings also, I think would show us that there may not be much in terms of germs, meaning that there's really no reason for doing environmental decontamination or fumigating rooms. I know Viral Kill, works on Newcastle for those who keep chickens, but this is not a chicken disease we are dealing with. This is a human-to-human transmissible disease that we are dealing with, and we know that it doesn't fly in the air. And so let's not waste money on fumigation. Let's not waste money on environmental decontamination. Let's waste money on things that matter. And things that matter right now are social distancing and masking. What matters most really is masking. Correct masking is, I think, what must be P1 for now. Let's get correct masks for everyone, especially for the health workers, for their continued well-being in the hospitals. That's a list of references that we can relate to. And this was the team that did this great study. I should thank Mr. Kennedy Chishimba from Eden University, who was actually the principal investigator on this study, but also our colleagues from University of Zambia, School of Veterinary Medicine, who partnered with us, and we had also some input from our colleagues at Center for Infectious Disease Research in Zambia, who partnered with us. But this was the team that did that work. Again, we would want to thank the government of the Republic of Zambia for sponsoring this study through the small grant that came from National Science Technology Council. And well, we should just say Eden is still uprising, but we really want to contribute to evidence, but we hope that all the evidence we bring out will be that which will influence policy. Thank you very much, Chair, and we'll be ready for questions when time comes up. Thank you.
Thank you so much, Professor Goma, for that presentation. Very insightful indeed, and it brings in a lot of issues to discuss, especially during this time when we have these surging numbers of COVID-19. Prof, we request you to just stop sharing your screen so that we have the next presentation. I should also say thank you for staying within the stipulated time. We will now invite Dr. Lombe to make her presentation, and we will have question and answers after her presentation. Professor Goma, there are some comments that are in the chat box. Please look out for them so that when we come to the Q&A session, you're able to address them. Over to you, Dr. Lombe.
Thank you very much. And thank you very much, NHRA, for this platform to disseminate the findings of our research. So today I'll be presenting on the results of a research study done at the Cancer Diseases Hospital investigating the stress, resilience, and moral distress amongst the healthcare workers during the COVID pandemic. So what must be understood is that delivery of cancer care is associated with significant emotional and mental stress for staff workers in such centers. This is known already. However, as everyone is aware, we had this specific event, COVID-19, that happened, and we felt it would heighten these factors leading to burnout, reduced resilience. This is very important because with burnout and reduced resilience, you don't achieve quality care for patients for whom it is intended. And if these things are not looked for, there's a cascading event. So even if you've got resources to treat patients, if you've got a healthcare system or healthcare workforce that is burnt out, that is catastrophic for the whole output. So we wanted to understand the factors that contribute to stress of workers in oncology during the pandemic. You must remember that cancer care is considered urgent care. We didn't suspend our services because most of our patients come from very geographically distant areas. Most of them are vulnerable, and it takes a lot for them to come. Cancer also doesn't wait and may have fatal outcomes if we delayed treatment. And as such, the response from other sectors were to scale down on outpatient clinics. But with the Cancer Diseases Hospital, we actually continued providing service at an almost similar level outside the pandemic. So we just wanted to understand the magnitude of the existing levels already in these healthcare workers. And we needed to generate evidence, as Professor Biemba had spoken to, that would feed into policy decisions for employee wellness that has an impact on patient care. And I think this is very important. And I do hope the results of this study will be used to look into the welfare of the healthcare workers who are at this center. So in terms of study design, it was a longitudinal cross-sectional study. We repeated it over a period of 9 weeks between July and September 2020, and 3 validated tools were used. So we used the perceived stress score, the Connor-Davison resilience scale, and the Moro distress thermometer. Then we added 7 independent items designed to inform the sources of stress that were rated on a 5-point Likert scale. So in the interest of time, I'm not going to go into these validated tools. They will be available. The article for this is in press right now. So these actually, you can read more about them in the actual article. And just know that they were validated. That's what's important. And these were the characteristics of our participants. So we had 185 study participants enrolled over a period of 9 weeks. And on the table, I'd like to draw your attention to the fact that here we have a total of 494 registered staff. So we had about a 25% participation, 20 to 25% participation of the staff at the center. Week 1 had the most participants with 117 staff members taking part, while week 6 had the lowest with 12, but we still felt we got valuable information even if we had low numbers, because as a collective, we were able to function. We function as a collective, not necessarily as individuals. Then the rest of the weeks had the following numbers. Week 2 had 41, week 3, 29, week 4, 25 staff participating, week 5, 28, week 7, 23, week 8 had 14, and week 9 had 14 as well. This really is about, survey fatigue that everybody, I'm sure, is facing. So we had a bit of drop off there. The largest absolute number of participants were nurses, but in terms of proportion to their absolute number, they were at 47%. The doctors were preceding at 80%. 28 out of 35 of the doctors took part in the study. So in terms of the perceived stress scale, the resilience scale, and Moro distress, as a collective at CDH, surprisingly, we had moderate stress levels. The medium perceived stress scale ranged from 20.5 to 23. We had a low resilience, which is very surprising for people who are working constantly in this high stress environment. And we thought that they were supported well and trained well, which was from 20 to 23. And we have significant Moro distress. And what the investigators actually felt was that The moral distress, which is basically when someone is not able to give a service that they know they should for a particular patient. We felt it wasn't just the COVID pandemic situation where services were being scaled down across the board, but this is just, it bore witness to the crisis in cancer care that is happening already, where we've got machine breakdowns, we've got chemotherapy shortages outside the pandemic as well. So the moral distress was not so surprising, but I think the resilience and stress levels were quite surprising for us. So in terms of the differences in the groups, there was a statistically significant difference between doctors and nurses with respect to stress, from work or financial concerns. The doctors scored 0.88 points lower on this question than the nurses. And it was felt that, it could be attributed to the fact that due to the COVID pandemic, the chances of actually additional income were reduced. Of course, this requires further investigation prospectively and validation, but things like reduced workshops, we were not allowed to have workshops. Workshops are usually additional income for most people, or moonlighting. The fact that you can hop from one hospital to another, again, they seemed to be that concern. Is that possible or not? Women, not surprisingly, had a significantly perceived stress score than men, and they had significantly lower stress from providing patient care than men. And they also had lower stress from the need for social isolation. And this is in keeping really with other studies that have been done in other places, including in Wuhan, where the outbreak was first noticed, and they have a longer period of observation of their cohorts. So they do find that women have they did find as well that women had higher stress levels. And for us as well, the fact that, I don't know, most of our cohort were nurses, and it was felt that the female ratio of the males were more from the contribution of doctors and nurses. And it felt like women have lower stress levels from providing patient care at that level because it is more natural to them. And they also didn't have that sense of the need of social isolation. The fact that when they go from work, they just stay at home. Women were able to cope better, or express that they were coping better compared to men. So there was no difference between women and men with respect to the resilience score and stress from daily work environment, stress from being infected with the COVID-19, or concerns of transmitting COVID-19 to others, stress from personal or family concerns, or stress from having children home from school. So we're not saying that these were not, just to clarify, the stress was identified across the board, but for these particular, what do you call them, analysis, there were no differences between men and women versus those ones where there were differences. So in conclusion, we felt that during the COVID-19 pandemic in the past year, the picture may be a bit different at this point, seeing that we're going through a sustained period of the pandemic. The economic situation is continually being, stressed, and the supplies are also continually being stretched. So we felt that the healthcare workers at the Seoul Cancer Center experienced moderate stress, high moral distress, and low resilience. We definitely feel it does have a detrimental effect on the quality of patient care and staff retention, could lead to burnout and generally indifference to the suffering of patients. And we do need to take direct and urgent measures that need to be instituted so that vulnerable patients are protected against these systemic effects. And it would also be prudent to have situations in place for further situations of pandemics or crisis from the findings of these studies to make sure that we are ready for them. So I would like to acknowledge the participants who are the staff at CDH and the study team who are listed there, participated in the data collection. Thank you very much.
Thank you so much, Dr. Lombe, for that presentation, and yes, for making it within time as well. We are now going to open it up for questions, comments, contributions. For those who are just joining us, you may have missed the first presentation. by Professor Goma, which looked at the environmental risk factors contributing to the transmission of COVID-19. I think Professor Goma had quite a number of recommendations in the end from the presentations. And we are now going to open it up for comments, contribution for both presentations. For those who are typing in the chat, please ensure that you put @ and the name of the presenter whom you are addressing your questions and comments to. Any takers?
So could I start with looking at the issues in my chat box?
Yes, please go ahead, Prof.
Yeah, so 3 questions in the chat box. The first one was talking about money. Did we look at money as a source of cross-contamination in people who have COVID-19? The answer was no, we did not really look at money. But we can use money from first principles, because all we are saying is just a surface. So as money remains a dry surface, yes, it can actually get the virus on it, but we would be hoping that because it's a dry surface, the virus would actually die quite quickly. So in my view, I would not really consider money as a serious source of cross-contamination. And there was a question here on disinfection. Were these homes disinfected? The homes we visited, the answer is no. The homes were not disinfected. We tried to get to the homes as quickly as we could before the surveillance team did anything else. And our aim was really to try and get the virus while it is still fresh on these surfaces. And you can see that we had quite a high rate of negative yield. And we suspect that most of that negative yield was because we were late. This virus does not survive on dry surfaces for a very long time. And so that is why we would be advocating for cleanliness and just drying up of surfaces to try and bring down the transmission. And then there was, it was more like a complaint from someone who said that he or she was admitted at the COVID center, and these nurses were actually using one pair of gloves, moving from bed to bed without sanitizing even those gloves or without washing them in between patients. Now, my dear, I think we can say that that was a poor practice. We have shown in our studies that we actually did find a virus on beddings. And so if it's a COVID ward especially, we know that the beddings will have the virus. And so in going from bed to bed, the nurses were actually transmitting the virus from one bed to another bed. And in these days where we have, all these variants coming up, we cannot be sure that this person on this bed had the same variant as the person on the next bed. And so that is a poor practice. We hope that the nurses are listening and they will stop it. However, we must say that this may be a result of shortage of nursing staff. And one nurse needs to trot from one bed to another. And you find that, sometimes there may be no chance of taking off those gloves because the next person needs your immediate care. And as such, people are forced to do that. I had personal experiences when we were in labor ward at one time where, there was just no time to change gloves, okay? But there would still be time to sanitize them in between patients. But really, I think going forward, we need to increase the density of health workers. We need to increase the density of people working in those wards. I'm sure you have heard me talking here of people who are cleaning those wards, that we need a higher density of them to make sure that they constantly keep the environment clean and the surfaces are kept clean and dry. And so apologies for what happened to you in that hospital. But really, let us bear with the nurses for now. And one take-home point from my presentation is that we ought to reduce on factors that may lead health workers to poor practices. And one of them, of course, is the density of healthcare workers. Those were the three, Chair. And so I think I've cleared my chat box for now. I'll wait for more questions if there will be any. Thank you very much.
Thank you, Prof. There is one more. I think there's some questions that are coming up. You can have a look at them. But while you are looking at those, we have a hand from Wube. Please go on and make your contribution within a minute, please.
My question goes to Dr. Lombe. I heard her justifying the stress among nurses with regards to financial stress that they found. And as somebody who is coming from the nursing background in Zambia and now in Australia, all I'm saying is that, is it possible for you to remove the justification? Because you cannot be saying, because there's no locum jobs, there are no part-time and no workshops and all of that as a justification for good pay. I'm not in Zambia, but I know to say the current governance has actually removed double jobs among nurses. So please, let's not justify. Let's pay attention to this problem which is there. There's financial stress, full stop. What do we need to do to improve on that? No justification of locum and part-time. Please remove it. And so make sure that it just comes out as financial stress because nurses are underpaid, full stop. No justification. Thank you very much.
Thank you so much, Wupe, for that contribution. Any reaction, Dr. Lombe, to that?
I'll respect her opinion. Thank you.
Okay, Professor Goma, I think you do have one or two more questions. Okay, maybe before Professor Goma comes in, we'll take another contribution from Dr. Lishimpe. Please go ahead, Doc.
Good morning. Thank you very much for allowing me to participate in this seminar of yours. First of all, I'd like to congratulate the speakers and the NHRA for organizing this event. I've got just a few observations for my brother, Professor Goma. He was being, I think, economical with the truth when it comes to social distancing. And especially in the season in which we are, the air is a little bit dry and the wind speed is a little bit increased. And so it must be remembered that there are other studies that have shown that these droplets can actually do 4 meters. So be very careful in, it can keep changing and depends on the circumstances that you are surrounded with. And then also, when somebody coughs, I saw somewhere where it says the virus can stay within that aerosol environment for about 45 minutes. And so you can imagine if the air is moving, it may even be more than the 2 meters we are recommending. So we need to keep, things are changing constantly. And so we need to keep on, looking at our recommendations that we are giving to the public. The second one is on the hospitals. Whether you are in a COVID place or not, the fact is infection prevention and control should be stepped up. But the problem is, what is the recommended time for swabbing surfaces? Is it every 2 hours? Is it every 4 hours? So in the COVID centers, I think it must be done more frequently, but what is that frequency? Is it every hour or every 2 hours? I want to believe that it's somewhere around every 2 hours. If you can really do it, we then can reduce on the cross-contamination from the surfaces. But if this practice can come down, even to the non-COVID hospitals, this way we would actually be preventing, cross-contamination quite effectively, even from other bugs other than COVID. I think with those two, I want to just thank Prof for that study that they did. Thank you very much.
Thank you, Dr. Lishimpe. One more question from Tisa. Tisa, please go ahead within a minute.
Yeah, sure. Thank you so much. I actually just wanted to follow up on what Dr. Lishimpi was saying. Professor Goma, thank you so much for the research that you did. I just wanted to find out if in doing your research and making your recommendations, if there was actually a body that you were already in touch with or in conversations with to try and figure out how we can best quickly implement some of those recommendations that are actually coming up, so that we quickly go into action in a time where what we need is not just data that sits on the table, but that data that's actually taken up and quickly imbibed or imbued into the systems that actually exist. Is there a body like that that you're working with directly? And is there something that you can do if it's not there to try and organize it so that we're actually working towards a greater goal of really creating?
Thank you, Mtise. Professor Goma, you can respond to that, and I think a few other comments that are in the chat.
Thank you very, very much. Thank you very, very much. It's good to have all of you colleagues joining us for this chat this morning. And as Prof. Biemba said, I think we just need to get more of our colleagues involved in getting some of these recommendations to the powers that be. There was a question here, I think, about what action should be taken to people within a home. I'm hoping that this is a question about people who live in a home where one has tested positive for COVID-19. What should the rest of them do? And I really think that, you know, if one is infected in the home, we have to be extra careful in making sure that the others don't get the infection. What I recommended, first of all, was that the person who is positive should actually use an N95 mask. Okay, so whenever they are coming out of their room and mixing with, trying to go to places where other people may cross, please wear an N95 mask. We would need to restrict visits to their rooms as much as possible. I think Dr. Lishimpi has mentioned how it is that, you know, when one coughs, there's an amount of virus that mingles in the air. And I think this is the same recommendation we are making for people to avoid crowded places. Even if it may be outdoors, you can't be certain that the virus has all fallen to the ground in the time that someone has been getting the virus into the air. So we limit visits to the room where a positive person is isolated, so to say. But the person must wear their N95 mask. For those who need to get in touch with that patient, they also need to be masked up, okay? In many times, I always encourage people to try and meet outdoors as much as possible. And I think it has done me personally well when I visit my patients with COVID-19. I like meeting them outside the house, okay? And keep 2 meters apart from each other. I think so far, so good. And so that's the way to go. The issue of implementation of some of these research findings, I think that has been our concern over the years. The National Health Research Authority has put in place a knowledge translation platform that can actually facilitate these measures. I would leave Prof. Biemba to comment on how well we are doing. On this particular research, this research is actually supported by National Science and Technology Council. The National Science Technology Council at the Ministry of Higher Education is actually a body that is supposed to support science and scientific innovation and scientific and dissemination of scientific information. And so in our presenting this report to the National Science and Technology Council, we were hoping that they would pick it up from there and take it into action. But I can see that they actually also don't have a specific mechanism of how that can be done. And so I think this is something that we need to continue to work on. But this morning, I think we have been given an opportunity to present this to the National Health Research Authority which is in direct contact with the Ministry of Health, which is the main body responsible for taking most of these things into action. So we are hoping that action will be done rather than us being just a talking show. I think that those were the issues on my desk. I don't think I've overrun anything else. But thanks, Dr. Lishimpi, for insisting on that distancing. We actually need to work on it, but I was really being economical with distance. All the best. Thank you. Bye-bye.
Thank you so much, Prof. And we are just 1 minute past the hour. Tise, I think the question that you have raised is similar to what Anisette had put in the chat, and we will have Professor Biamba speak to how we move these into implementation in his closing. But before Professor Biamba comes in, there's one last question that has been put in the chat for Dr. Lombe. I would request you to just address this question within a minute, and then we are going to invite Professor Biamba to give us some closing remarks and respond to how these actions can be translated into practice and policy. Over to you, Dr. Lombe.
Thank you very much. And thank you for the question, which says, how exactly did you control for investigator bias where participants are aware you're checking on their stress levels? This may have a positive and negative effect depending on who they perceive you to be. Thank you. That's a very good question. And I'll just repeat the study design. So it was a blinded questionnaire. It was repeated measures, and we asked people to keep their code secret. And they were given questionnaires to fill in on their own and then return them to us, and it was anonymized. So I believe that's how we tried to reduce that bias. Thank you.
Thank you so much, Dr. Lombe, and everyone else. Dr. Lishimpi, I'm not sure if that is an odd hand or it's a new hand, is it? Okay, seeing that his mic is muted, I will invite the director to respond and give us the closing remarks.
Thank you so much, Kuta, and thank you so much, the presenters, Prof. And Dr. Lombe. Thank you so much. For me, I have learned a lot. As I indicated at the beginning, this is not just business as usual. This is not just routine work. We want to make sure that whatever has been presented is translated, but how do we do that? We have a knowledge translation platform at NHRA that basically looks at policy and program relevant evidence as it emerges. This knowledge translation platform has a secretariat headed by a deputy director, Sandra Sakala, and the one who is coordinating right now, Kuta Banda, is our senior knowledge translation officer, and we have other staff that assist. We have even a multi-stakeholder group that consists of different people, which meets every quarter. And that basically advises us on how we can ensure that the evidence that is generated in the country is translated. But in simple terms, after you have, after this presentation, we'll look at the recommendations that have been put, and we develop a policy brief together with the people that are presented. Not everything that has been presented goes to the forum. Or basically ends up being translated into action. But we do present a policy brief or prepare a policy brief together. So for example, Prof. Goma has made specific recommendations. What we'll do is to look at those specific recommendations, and we'll not just take those recommendations as they are, we'll look at other evidence that is available, and then we will develop a policy brief and present that to the Minister of Health. And there's a process of getting that into actual action. So once the policy brief has been presented, there's a follow-up policy dialogue that takes place. And remember that the audience is not just the Ministry of Health. We have other audiences, but we use that forum because the ministry is responsible for all health actions together with other stakeholders. But we will go through the Ministry of Health through the Permanent Secretary's office. So I can assure you that this will not just lie on the shelves, and you are welcome to also follow up to say, yes, there were these issues. How far have they gone and what has happened? I think that would be very helpful also for you to follow up with us. But there are very, very specific recommendations that have been made. Even the one that Dr. Lombe has presented does present relevant policy decisions because we can see that the levels of stress are quite high, but also the resilience is low. And that's a very, very important finding because it does reflect on how we cope with the stresses. This is the Cancer Diseases Hospital. How about other places? What's happening? We don't know. So we'll look at that evidence and we'll also look at other evidence and then try to develop policy briefs and ensure that action is taken. So with that, I want to thank you. We are 6 minutes past, but we started also 6 minutes past. So this is exactly 1 hour and we appreciate, we wish you all the best. Keep safe. The pandemic is raging and I would urge you all to overdo the protection measures. I actually want you to overdo things. If you want to sanitize, over sanitize. If you need to wash too many times in a day, there can never be too many times. I want you to overdo things in terms of protection because the pandemic is really too bad for us. Thank you so much, Kuta. You have done a wonderful job, and the team. Thank you so much. We end the meeting.
Thank you so much for those closing remarks. Just a few notes. We do post the abstracts for these presentations on the NHRA website. So when you go to the NHRA website, just look out for the COVID-19 monthly meetings. You will find the abstracts there. We also put the contact emails for the presenters. We also will put the Zoom recording there, so you can still feel free to go back and watch or listen to this. We request, like Professor Biamba said in the beginning, when you receive these emails, the COVID-19 meetings happen every last Wednesday of the month at 10 hours, same link. So when you receive this, please feel free to share with your network so that we have more people engaged in these discussions. We will not be able to upload the presentations because some of these studies have not been published yet. So unless the presenters allow us, but we will have the abstracts there. So, and the contact emails for the presenters, and you will be able to access that. Thank you so much for your time, and we look forward to seeing you at the next COVID-19 monthly meeting, which will be the last Wednesday of July. Anyone that would like to present at these meetings, please reach out to us so that we can add you to the scheduled presenters. Have a good day, everyone, and thank you again for joining.
Thank you. Bye.
Thank you very much. Bye-bye, Chair.